All attendees are in listen-only mode.
Good afternoon, everyone, and welcome to the webinar. My name is Ashley Moore, and I'm the Vice President of Marketing for MedEvolve. In today's presentation, we will be diving into a very important question that I think we all want the answer to. Is your practice leaving money on the table? I just have a few instructions, and then we'll get started. As you may have heard at the beginning, everyone is in listen-only mode, so you're muted. If you have any questions during the presentation, you should see a box to the right of your screen, similar to the one shown here. You can submit your questions there at any time, and we'll do our best to address them at the end of the presentation. If you don't see this box, the questions box, you can access it from the control panel that's located in a tab at the top of your screen. Additionally, if you have any issues during the webinar, there's an option to raise your hand. So if I see your hand raised, I will do my best to resolve any issues. And now I'll let our experts take over the presentation. Amy?
Thanks, Ashley. Good afternoon, everybody. My name is Amy Heckman. I am one of the presenters and just want to tell you a little bit about myself. I have been in the world of medical billing longer than I like to admit most times. I have officially more than 25 years of practice management experience, but my unofficial start came when I was probably 7 or 8 years old. My mom managed a medical practice and figured out that you could teach a 7 or 8-year-old how to run a 10 key and add up the charges, payments, and adjustments columns on the old ledger style billing. So I have literally been around medical billing all of my life, and I have found that, you know, I started in the industry back when HMOs first really started out, and we actually liked them back then because we knew what we were going to get paid. We got paid quickly, but as I'm sure you can imagine, times have changed. So we're going to share some information on what we've learned over the years, and before we get started, I'm going to let my co-presenter Matt tell you a little bit about himself.
Welcome, everyone. Appreciate your time in joining this webinar. I first want to apologize for my voice. My 6-year-old decided to give me an early Father's Day, very early Father's Day gift of a head cold. So I will do my best to be articulate. I have worked with MedEvolve since June. I came on board as a consultant to help finish the development and the deployment of the Practice Analytics Business Intelligence solution, which sits on top of our practice management system. Prior to that, I've spent 17 years in healthcare, primarily revenue cycle management, consulting, and technology, and really been focused on process improvement and where we can embed, you know, people redesign, technology deployment, and help protect revenue for both on the acute side and the ambulatory side. So I'm excited to take you through some of this information and look forward to the questions and any follow-up after. And I'm the Senior Vice President of Business Development as of January, so I did come on full-time this year. All right, let's walk through MedEvolve. For those that are not familiar, we are a privately owned corporation. We've been around since 1998, headquartered in beautiful Little Rock, Arkansas. We've got 104 U.S.-based employees in the company. We do have clients in 46 of the lower 48 states, including Alaska. And we've done a lot of healthcare transactions over the course of doing business. The nice part about doing all these transactions and now having the analytics is we get to see a lot of trends and patterns, many of which impact revenue. A lot of these trends and patterns we'll talk about today. We're going to walk through some of those areas, hopefully provide some insights and some tactics for you all to take back to your practice, and as we like to say, not leave money on the table. Healthcare is challenging enough, regulations are challenging enough, so we want to make sure we can help you protect every dollar in good revenue that we can. Amy's going to walk us through the overview and the objectives of today's webinar.
All right, thanks, Matt. So we've kind of labeled this as identifying the leaks. We're talking about money being left on the table, you know, dollars that are legitimately a practices, you know, to collect, and we're finding that there are some trends that and some typical areas that we see that those don't necessarily happen as efficiently or effectively. So what we're going to be talking about today are first eligibility and benefits verification gaps, then the increasing patient responsibility balances that we are seeing in the industry in the last few years, avoidable rejections and denials, and then some contractual underpayments. And then we have a section, basically, we're talking about sort of the vital signs. What are some of the signs that may be pointing to what the problems are in your practice that you may be missing? So without further ado, we're going to jump right in, and we're going to talk about eligibility and benefits verification gaps. The number one cause of rejections and denials in the data that we have been processing and what I see in my consulting practice is rejections related and denials related to eligibility. And these can range anywhere from flat out, patient just does not have the coverage, coverage, may be terminated prior to service being provided. So maybe, you verified benefits when the appointment was scheduled, but by the time the patient came in, they no longer had that coverage and didn't bother to tell you. A lot of denials as well, coordination of benefits denials, is going to the wrong payer, and just a number of denials, and we'll go into a little bit more detail on some of those, but that's the number one cause of rejections and denials we see, and it can lead to a lot of different types of lost revenue. For ACA plans, the Affordable Care Act plans, one thing a lot of people don't necessarily realize is you may need to call, after confirming those benefits, excuse me, you may need to call further if you see that it is an exchange plan and find out if the premiums are current. Because one nasty little trick that we've seen with a lot of payers is they will continue processing claims for up to 90 days past when a patient has stopped paying their premium. And if that premium doesn't get paid in those 90 days, that's it. You're not going to get the money that you're owed for those services you provided that entire time. So it's very important to make sure that you confirm that the premium is current. And unfortunately, a lot of times that requires a phone call. Also, another area we see people losing money is Medicaid eligibility. Patients eligible for 4, 5, 6 months, and then all of a sudden, because of an income level or something that changed for just a month or two, they're no longer eligible, and it's going to be tough to collect that money if you don't know about it up front. And the last point that I wanted to make in regards to eligibility and benefit verification is it's critical to make sure that you're scanning photo IDs and insurance cards, and this is the big part, ask patients about changes to their demographics at every visit. And don't just simply say, has anything changed since your last visit? I hear that constantly when I'm in practices. The proper way to ask that question is to say, is your address still at whatever street? Give them a piece of information that they have to actually stop, think, and verify. Because it's really easy for people to just say, oh yeah, no, everything's the same, and not realize, hey, I moved a month after I last saw my doctor. So just some kind of simple things that if you just put a few of these into place, it's going to stop a lot of those eligibility denials and rejections. And as everybody knows, it's a lot more efficient to work those things and fix those things on the front end than to go back and try and collect that money after the service has already been rendered. We've got a few more detailed pieces that we're going to talk about here about what some of the specific areas that verifying eligibilities can impact and can improve. And I'm going to let Matt talk about some of these issues because he's done a little bit of data crunching on some of this.
Thanks, Amy. So, Amy's spot on with the verification process. Making sure that we truly understand whether they have the correct coverage, the right insurance plan is selected, and we understand the patient responsibility. So we have an opportunity to collect that money at the point of service or prior to service. Some of the things that can happen, which we're all familiar with, but does impact your net revenue, is your delay in payment, your delay in cash flow, the amount of work that has to be done in the back office, billing office, to overturn denials. A lot of the soft denials are easy to fix, but if we had fixed them if we had done the right thing at the right time up front, it never would have happened to begin with. We're seeing a lot of coordination of benefits denials, so making sure we understand who's primary, who's secondary, and how that works. Benefits exhausted is another area. Timely filing is not something we never want to see, but we do. When you think about the patient liability piece, being able to correctly estimate, what that reimbursement should be from the patient. We do see rising bad debts due to, as Amy was talking about, demographic information. If we can't get the right address, we can't get the phone number, we get a lot of return mail. That's a lot of processing time. Again, cost to collect goes up, and we don't want to see that. When you look at selecting insurance plans, if we're going to talk about contract management here in a little bit, payment compliance, but it's imperative to get the right plan in place so you understand what you should be collecting from the payer, and then when you audit what you actually got, whether you're being underpaid or paid appropriately. And all of this really ends, unfortunately, with a lot of potential decline in patient satisfaction. I've seen that over the years, is even though the patient didn't give you their current address or didn't tell you they changed insurances or jobs, they're upset that they get sent to collections. They're upset that that nobody told them how much they were going to owe. So, in the consumerism world that we live in, we've got to stay focused and keep top of mind the customer. Just a high level, taking a look at some denial information, and the graphs that we'll show you today are actual clients, de-identified, of course. But being able to run those eligibility and benefit checker every time, being able to do batch eligibility checking. This should be done prior to service, at the worst case at point of service. But for these elective visits, there's no reason. We know the patient's coming in tomorrow. We should be able to do this prior to the service being rendered. If you look at the denial trends, I mean, you can see the downstream impact of eligibility issues. COB is right up there. Eligibility. Looking at medical necessity, there's lots of things that go into delayed payment, and some of these unfortunately are hard denials, which will not be overturned, which is impacting your net revenue. And the CFOs on the call will understand exactly what I mean by that. So,
all right. Sorry, Matt.
Pass it to Amy.
Okay.
Patient responsibility.
Yep. So increasing patient responsibility is the next area that we're going to talk about, and this is something that I'm sure pretty much everyone on the call is probably painfully aware of. Over the last few years, as deductibles have increased and patient responsibility in co-insurance has increased, the time to collect your hard-earned dollars has been extended. The actual full revenue cycle has gone from getting 80% or better of your reimbursement from the payer within 14 to 30 days, obviously with some exceptions or some that take a little bit longer, but for the most part, especially if you're set up for electronic remittance, I've seen payments in less than 5 business days in some cases for those. So we've shifted the revenue cycle length from 14 to 30 days to now, if you're having to wait for a patient to pay, that 80% that you used to get from the payer, you're looking at 45 to 60 days sometimes if you're not good about establishing what that patient responsibility is going to be at time of service, verifying their benefits to find out what deductible has been met, and making some changes to your financial policies and your practices and to accommodate that. So, one of the things that you need to remember is, payers are bound by prompt payment laws. They are required to respond to, whether it's with a payment or a request for information or denial, claims within a certain period of time. It varies by state, but it's typically hovers somewhere around 30 to 45 days. Patients, you don't have that to your benefit. And one thing you may or may not be aware of, but recently the credit bureaus downgraded the weight that medical bills have on credit scores. which basically means that that's the last thing patients are concerned about paying in most cases, because they're going to worry about the things that are going to impact their credit score. So it's important to utilize patient payment tools such as credit card on file systems that allow you to securely store a patient's credit card information and establish payment plans, but also more importantly, establish financial policies where if you have a new patient coming in, you verify their benefits and find out that they have $6,000 of a $6,500 deductible remaining for the year, and your services are going to cost them about $400, rough estimate. A lot of practices are putting financial policies in place that the patient signs that says, we'll bill your insurance. Anything that is applied to deductible, co-insurance, we need a credit card on file, and that will automatically be charged. Typically, they put a maximum amount. If it's $200 or less, it automatically gets charged the full amount. If it's greater than $200, they break it out into $200 plus X number of monthly payments. Important thing to remember about this, a credit card on file system is not having patients fill out a form that has their credit card on file that you store in a file drawer somewhere and once a month pull out and run. That is begging for a red flag rule kind of fraud situation. There are great tools out there, great companies that jump through all of the hoops to make sure that you're in compliance, that the information is not stored someplace where an employee could get a hold of it and you'd have to worry about fraud or embezzlement. So we're going to talk a little bit more about some of those, how those things can be used as well. But overall, the number one takeaway is patient responsibility is going up. We have to be more proactive and more creative at times about how to collect that money at time of service rather than waiting until the full revenue cycle from the payer is completed, because you're going to cut some time off of your revenue cycle that way. Matt's got a couple of things we're going to talk about, specifically some of the technology, and I might have stole a little of your thunder, but I'm going to turn it back over to Matt.
Amy, you always do that. It's okay. Yeah, just to reiterate, I mean, where we were 10 years ago compared to now with technology, there's so many innovative companies out there that are niche players and allowing you the ability to identify how much a patient owes, make it seamless in terms of collecting their balance for that visit, making it seamless in collecting the balance on other visits that may be outstanding. A lot of good PM systems have it already integrated into their platform, making it a much more easy and seamless way to do it. Prompt pay discounts, payment arrangements, financing programs, there's lots of different ways that you can go about working with the patient who, for those procedures that they're coming in for. And, we talked a little bit in the last slide about regulation. I mean, you do have to be careful when it comes to things like prompt pay discounts and what the insurance companies are able to do. But again, do the research, understand what controls you have over those higher deductible plans and how you can work with the patient to get their bill adjudicated. I was talking with Amy earlier today as we were preparing for the webinar, and we all have to remember, we're not an emergency room. That's a good thing. So we have time. We schedule these patients. We can let them know what they're going to owe. We can work out that payment arrangement prior to service and collect at the point of service at the latest. And let's make it easy on the patients. There's text, web, mobile. Who knows what will come out next month? If I can use Venmo to pay my friends for dinner at a click of a button or a haircut, we're going to be able to do the same with patients because the patients are already using these technologies for other services in the different industries. We'll take a look here at a client. This is, unfortunately, this is something that we're seeing all the time as we are taking clients live with our analytics solution and looking at the self-pay receivable. This is a client that has over $1 million sitting greater than 30 days. There's a risk now of a lot of that going to collections, a lot of it being written off as bad debt. There's collection agencies. Many of you use collection agencies. It's always a bad term. I'm sending you to collections. And those collection agencies charge a lot of money. You know, I mean, I've seen 30 to 50%. And so you start thinking that dollar that's owed to you, if you have to give up 50 cents on that dollar to an agency, and you could have collected that at the point of service, that's a big influx of cash flow for your organization. And we talked about patient satisfaction. You know, at the end of the day, you know, nobody wants to get that collection letter. Nobody wants to realized that, you know, the address on file was from 3 addresses ago, and there is some patient responsibility there in making sure everything's up to date, but things happen. So, you know, in this market of competitiveness, it's important to make sure we're doing everything we can to evolve the consumer focus and make sure that we're working with our customers the best we can. We're going to go ahead, Amy.
I was going to say, to follow up with that and kind of tie a few of these points together so far, you know, you talk about 30 to 50% being paid to a collection agencies, and referring back to what you said in the previous slide, if you can, wouldn't you rather give a patient a discount if you're going to end up losing 30 to 50% because that's just become the cost of getting that money collected? You know, your patient satisfaction rates are going to be much higher if you say to the patients, look, I'll work with you. If you can pay it on time and pay it promptly, we'll give you a discount. So avoid the collection agency at all costs. I'd much rather give a patient a discount than to give it to a business. Oops.
I think we're going to move into looking at
denials. Yay.
Rejection. Our favorite.
Our favorite topic. All right, so avoidable rejections and denials. So you can't avoid them all, but rejections, I would say you should be able to avoid, I mean, and I say this because I've seen it, you should be able to avoid 99% or more of your rejections. I've worked with clearinghouses and with groups in the past, and they have, there's one out there, they have their 99% club where their clean claim rates are 99% or better. I have one biller who, when she does her charge entry and submits her claims, she can count on one hand the number of front-end rejections she gets in a month, and if it gets over that one hand, she's pretty upset. So there are ways to really keep that clean claim rate up there. The average clean claim rate, and this statistic came from a recent survey, so it's pretty fresh. Average clean claim rate, which this means it gets through to the payer the first time you send that claim out, is less than 90%, and that's an average. I have seen as low as 50 to 60% clean claim rate. So that means 40% to 50% of their claims they're having to touch just to make it through to the clearinghouse. There's a lot of practices that don't effectively work their rejections and denials. This is one of the #1 causes of timely filing denials that I see. We sent it out and nobody ever bothered to check did it actually get to the payer. And with 60 to 90-day timely filing ranges for some of the payers, you just don't have time to take that chance. So when I set up my teams, or when I make recommendations to a practice, if they have multiple people working in the office and somebody handles charge entry, somebody else handles payment posting, I kind of have a rule set that the person who's doing charge entry, their job's not done until they have been able to confirm that the payer has that claim. So any kind of front-end rejections are worked by my charge entry or posting people. Once that claim has reached the payer, their job's done, they go on to the next one. Now it shifts over to the payment posting individual. So if there are denials that come back in the process of posting an EOB, I want those worked right away, not set to a queue. And I've seen people that we work our denials once a month, or we work our denials on Fridays. Every day you wait to work on that denial is one more day it takes to get your money, and is the chance of that slipping into a timely filing process, because you've got time limits to get claims back if they've been denied, and to do appeal or a reopening. Another area where I see a lot of problems is those things just getting written off, not worked. And this is where I always recommend a policy of any kind of non-contractual write-offs should be approved by an practice manager or provider. Go a little step further, and in most practice management software, you can run reports and review reports to see if the full charge amount was adjusted off. Anytime the full charge amount was adjusted off, you want to at least spot check that, if not check everything, just to make sure that somebody's not keeping their AR clean by just writing everything off that doesn't get paid. And finally, it's important to understand what write-offs are occurring that are not contractual. They're for other reasons. And Matt actually has kind of a pretty good acronym that he talks about, so I'm going to let him give you some detail on how to determine and address some of those other non-contractual write-offs.
Yes, it's very unique. It's called the ABCs. When you look at the deductions to the charge or revenue, once you take that contractual, everything else should be a payment, either a patient payment or an insurance payment. But many times what we're seeing is administrative write-offs. We're seeing bad debt write-offs, charity care write-offs, and sometimes other write-offs. That's where you really want to scrutinize, with your analytics solution, you want to scrutinize those other write-offs to see why they're occurring. Do you need to change policies, procedures? Do you need to look at your transaction codes? We have a lot of clients who roll their transaction codes up to categories, so they can actually understand those deductions to revenue and what they're for if it's not coming in as a payment. So very, very important to understand as we look at maximizing net revenue for ourselves.
I skipped ahead on you early, but here you go.
Okay. I'm good. Keep my head on a swivel.
There you go.
We're going to move into contractual underpayments. Payers don't underpay, right?
Yeah.
I know no one can laugh, or we can't hear you laughing. But,
I'll laugh for you. Ha.
Thank you, Amy. Ashley, I need to laugh.
Yeah.
So, when we look at contractual underpayments, you really have to understand your fee schedules. You need to make sure that those contracts are current and they're loaded into your practice management system, and available. And then you need the analytics to sit on top of that so that you can actually really estimate reimbursement based on that fee schedule and compare it to the allowable amount and compare it to the payments that you received. That's going to help you identify potential trends and where you may see underpayments. And what we've discovered is even though it may not be huge at a charge by charge level, when you start to aggregate them, it starts to become a material amount of money that you can go back to the insurance company and have a discussion with them. We always ask the questions, when's the last time you negotiated or renegotiated your contracts? What data and information are you bringing to the table when you negotiate those contracts? So a lot of the information we're sharing today, they're data points that you can, I always call it a scorecard, where you could sit down with a payer and say, right now you're a C- because of these 5 reasons. I want to get you to a B+. This is so let's see what we can do together to get your score up. So it puts more control in your hand, which is important when negotiating.
And I'll tell you, Matt, I do seminars sometimes on this very topic, and this is the point in the seminar where I would ask everyone to raise their hands of, who's never renegotiated their contract, and a significant number of people sheepishly raise their hand and say, I didn't even know I could. It's tougher than it used to be, but it is possible. And it, again, like Matt said, it requires data. It requires you to be able to go to that payer and say, look, I'm providing excellent care to your patients based on these, statistics, and that's going to come from a clinical perspective, and you're providing me mediocre reimbursement. We need to talk about this.
The business of healthcare.
Yes.
Put a couple of graphs up here just to provide some more context for you all. So when you want to have quick access, immediate access, and drill down capabilities at the payer level to see where the variances are occurring. So understanding over time, where you may have buckets to look at, and then being able to drill down and looking at specific payers to see. I mean, if Blue Cross is an issue, then we need to drill down further into that and start looking at the CPT code categories. We can look at the individual codes. We can identify trends and where possible underpayments and bring that information back to the table with them. So how do we know how well we're doing? That's the big question, right? I mean, we've talked about a lot of information, and you know, you'll hear measure to improve quite a bit as we wrap up the webinar. But Amy's going to take us through vital signs and what vital signs are critical for your practice to know at a moment's notice whether you're doing well or you're not doing so well. And if you're not doing so well, how can you improve and what do you need to improve?
Great, thanks, Matt. So one of the biggest mistakes that I see when I, go in to do a practice assessment or when I'm working with a new practice is they say, my days in AR are great, or my, X is good, and they only talk about one point. Focusing on one single measure of your revenue cycle can cause a misdiagnosis of what the problems really are. I hear clean AR. Our AR is really clean. My biller does a great job. We don't have anything over 90 days. What they don't realize is the reason they don't have anything over 90 days is something we talked about already. That biller is just writing off things rather than going after them, because every time she knows she's got to, give a report to the provider, oh, let's go clean everything up. It's important, when we're going to, I just had, my checkup at my doctor, and we have to measure multiple vital signs, because that's going to tell, just because I have high blood pressure, maybe everything else is okay, and we look at multiple vitals when we're trying to determine how healthy a person is. We need to do the same thing with a revenue cycle. So, clean AR plus net collections, plus days in AR, acceptance rates, combining a few pieces of information is going to tell you what the true health of your revenue cycle is. Days in AR is something that probably 90% of the practices I work with have some idea of. They either measure days in AR or percent of collections over a certain time period. But if you don't pair days in AR with net collections, which net collections, if you're not familiar with that term or you've used a different term, is, of the dollars that you're able to collect. So taking your contractual obligations out of it, because we all inflate our fee schedules a little bit, and then we write off those CO45 adjustments. So once you take out all those CO45 adjustments and the things that are contractually obligated, out of the total dollars that you billed that you should have been paid for, what percentage of that did you actually collect on? That's the critical number, because if your days in AR are great, but your next net collections, let's say you've got 30 days in AR, but a net collections rate of 80%, that tells me somebody's just writing things off. They're not going out and working those denials. Your clean claim acceptance rate is important. We already talked about that a little bit, so I won't go into too much detail. Days to bill and charge posting lag, those kind of go hand in hand. And sometimes the charge posting lag can be a result of charges not getting to the charge poster from your providers. We see this a lot with surgeries. I have a practice I work with where the doctor, it's primary care, she does a lot of nursing home visits, and she'll give us 2 months worth of nursing home visits at once. She'll just go for 2 months, see all these patients, and that's money just sitting there waiting to be collected. The other danger with not keeping an eye on their days to bill and your charge posting lag is you've got timely filing deadlines. So if something goes wrong with that claim and you've already used up 30 to 45 of your days to file just getting the charges in, it gives you a lot less time to fix whatever problems may have occurred. And not to mention, it's your money. It's just you're waiting longer to get your money. Another measure is days to collect your patient liability. So of your accounts receivable, what percentage of that is patient responsibility over X number of days? Those are the ones that even with practices that have pristine insurance accounts receivables, nothing over 90 days. You add in their patient receivables, and you've got stuff over 120 days in the tens of thousands for smaller practices, and as Matt showed you on some of our examples, it can get up into the millions. A couple other measures that I threw in here because I've had to use these a few times in some practice assessments are average number of encounters per provider and their average reimbursement per visit. These are important because in the case of the average number of counters per provider, I had a client who they were falling short about $10,000 a month in their collections. You know, they usually collected about $100,000 a month. It was a smaller family practice. They were dropping about $10,000 a month from what they'd been the previous year. And they, of course, thought that it was, you know, my billing company's fault. And when I ran some numbers, I said, yeah, you're averaging 18 patients a day per provider when you used to average 22. So if you just increase 2 patients per provider per day, there makes up your $10,000. Same kind of things with your average reimbursement per visit. Payers are notorious for suddenly changing the rules and deciding that this particular add-on procedure is now bundled in with this other one, or, you know, and whether it is or not. It may not comply with CCI edits. It may be allowed. They make a rule change, and all of a sudden, something that you do a lot of, they're stopping the payment on it. They're now making you fight for that money. And again, if you're not keeping an eye on those denials, your average reimbursement per visit could go down. So those are numbers that you want to watch if you happen to see you're working, and the common phrase I hear is, I'm working as hard as I ever was, and the money that I'm collecting is, you know, not the same. And then lastly, first pass denial rates and denial overturn rates. You know, and Matt, I'm actually going to throw these to you because I know you had a couple of comments, you know, as far as being able to track and determine what those denial overturn rates are.
Yeah, you know, I think, you know, the first pass denial rate is important because it lets you know where some of the issues are. In the earlier chart that we showed, you can see that, you know, a lot of these denials are, I consider them soft, meaning that with intervention, you can overturn them, but that means you've got staff that are proactively working those denials and not letting them pass the appeal statute. And then denial overturn rate is important also for a couple reasons. You know, most importantly, it's you want to know that, well, if I got denied $100,000 and I overturned 80, that's a good thing. Now we need to fix process up front so that we don't get the 100,000 to begin with. But it gives you an idea of the areas that you do need to focus on. And some of the ways that we've calculated that is you can look at, you know, that last denial date on that charge, and you can look at insurance payments that are collected on that charge after that denial date. It's pretty straightforward. Any good analytic solution will have that, and it'll give you an idea of where you've got opportunities. The one thing I would add, you know, on the looking at really productivity that Amy was talking about is, you know, sometimes we forget about payer mixes, payer mix changing. You know, so being able to understand, you know, where your patients are coming from, the demographic, the types of procedures that you're doing, and understand that, you know, that will impact cash flow. You know, if you're seeing a spike in Medicare away from, say, Blue Cross, Blue Shield, or some of the other higher paying commercial plans, you're going to have an impact to cash flow. We work with a lot of clients on helping build the picture, the big picture on how cash is trending, why it's trending the way it is. And so it's important to factor all those in.
Great. And more data. Matt's favorite.
More data. My favorite, the data guy. Somehow got branded like a decade ago and can't get away from it. You know, measure to improve. It's funny, when I started my career in consulting, it's probably a bad term, consultant or vendor, I'm not sure which is worse, but I've been both. Measure to improve was by far the philosophy. You know, if you can't measure it, you can't improve off of it. And it was the way that we were able to understand how well the project was going. If it wasn't going the way we wanted to, you know, how we could quickly audible and make changes. So data nowadays, you know, business intelligence, analytics, big data, predictive analytics, you know, artificial intelligence, all these terms, you know, that you see at the trade shows. I mean, it's been around long enough in other industries, and it's made its headway into healthcare. So, you know, your data needs to be available in a real-time or near real-time basis, you know, to really augment the analysis you need to have at your fingertips to identify root cause issues. You know, further, you've got to be able to structure the data and present it in a way that improves the decision-making for the organization. So whether it's a mobile capabilities, web capabilities, whether it's to push analytics out to users that need to see it. You need to be able to see those we call them key performance indicators to understand how your organization is doing. So it's important. Data is really, it drives our business. We're focused on a data company now, making decisions based on what the data is telling us.
Great, thanks, Matt. So, believe it or not, we've kind of covered everything, and want to wrap this up a little bit. There are a few key pieces that we talked about, and if you wanted to sum it all up into one slide, here it is. So we've talked about being proactive with patient responsibility. Don't surprise a patient with a $1,000 bill 18 months after the process, and you avoid doing that by having those conversations with the patient at the time of service, making sure you understand what their estimated responsibility is going to be, making sure that your claims are getting adjudicated in a timely manner so that the statements are going out and at a reasonable time. Address your rejections and denials quickly. This is probably one of the biggest areas that I work with practices on, is putting workflows in place that make sure that we eliminate every possible rejection and denial that we can. They're never going to eliminate all of them, but by making sure you take advantage of eligibility verification tools, some of those, denial management tools where you're tracking things, you're making sure that, and this is something we may not have really talked about in the presentation, but make sure that when you're tracking your denials, that feedback is getting moved upstream in the revenue cycle. So if the payment poster person's working their denials and they keep seeing the same missing modifier 25 or missing whatever it is, make sure that that feedback is getting pushed upstream so you don't keep chasing the same problems. Addressing your rejections. If there's constantly demographic errors and those kind of things, might need a little more training with the front desk person or whoever is responsible for doing that kind of data entry. And then we move on to monitoring your KPIs, those key performance indicators that we talked about. You don't have to do them all. You'll probably know which ones are going to be most relevant to your practice, but pick at least 3 or 4 of those things to monitor, because as you remember, just monitoring days in AR or just monitoring one particular key performance indicator can give you a inaccurate diagnosis of what your issue is. And then finally, Matt's favorite, utilize data to identify trends that are signs of those revenue leaks. So, as I mentioned at the beginning, I've been doing this since, we were dealing with pegboards and carbon paper and ledger cards, and it didn't require a lot of analytics and a lot of data analysis. I mean, you pretty much, you sent a claim out, as long as it was great. Our biggest problem was, did it actually get there? Did the post office lose it? Or, those famous things of, they got 20 of your claims and somehow the other 10 that were in the same envelope didn't get there. That used to be the biggest problem that we dealt with. We need data now. Healthcare, unfortunately, whether you like it or not, is a business, and you have to be prepared to address those business issues. So, as Matt kind of alluded to, and one of my favorite sayings with clients, you can't fix what you don't measure. If you have no idea what's broken, you're never going to be able to fix it. So, at this point, we're going to throw back over to Ashley to see if we had any questions come in. Ashley?
Yes, thank you both for the very insightful presentation. We did have a couple questions come in, and also if anyone else that's still on has a question, just enter it in the questions box and we'll see if we can get to it. So the first one that came in is, can you legally give a discount on an amount applied to a patient deductible?
All right, you want to take that one, Matt, or you want me to?
All you, Amy.
All me. Okay. So my favorite answer to most questions is, it depends. People, get kind of tired of that. So the short answer is, yes, you can offer discounts. You have to be careful in the way that you do it. So, and where a lot of the fear and trepidation that providers have in offering any kind of a discount, or it's, they use the term waiving copays and deductibles. A lot of that comes from, dealing with CMS and dealing with Medicare. And years ago, I found the actual definition in a manual that talked about what Medicare considers fraud. One of those things is routinely waiving copays and deductibles. And their logic in that is, if you say it costs you $100 to provide this service and we pay you 80% of that, you should collect 20% from the patient. If you can afford to just give that patient a discount, you should be giving us the discount. This has become a trickier situation. It's become a more problematic issue with these high deductible plans. So one of the things that I have always told clients is you have, if you're making that offer right up front and you're just saying, oh, we're just going to waive this person's copay every time they come in, and I see this little notes put in the system that says, don't collect a copay, it's doctor's brother, don't collect. Those are the areas that can get you into a lot of trouble. Number one, it's important to review your contract documents with your payer. Typically, the language they include is that you cannot offer, another payer or another individual a better rate than what you're offering them. So across the board, no, you can't just simply say, we're just going to waive or discount everybody's deductible or this particular person's deductible all the time. What I recommend to practice is, to make sure that you don't get into any trouble, is if you have a financial policy in place that clearly states, what your hardship discounts are. Typically, that's what you typically have to address it as, is, is there a true hardship? If you're just saying, oh, we're just going to waive it because the patient asked us to, that's where you can start getting into trouble. It's when they see patterns in an audit that you can really get into trouble with waiving copays and deductibles. So if it's a matter of, you've sent a patient, 2 or 3 statements, they say, hey, I'm having a hard time, I've got some financial troubles, I've got a lot of other medical bills, can you work with me? That is a very different situation than just simply saying, we're going to waive, our copay or deductible completely for a patient. And I've seen practices get into trouble for that. I've had clients that I lectured and lectured and lectured and said, you cannot simply say, I'll accept whatever the insurance covers on this patient as an ongoing basis. So there are ways to legally and legitimately discount deductibles, but you need to, number one, review your contracts, make sure that you are doing it within compliance of your contract. If you're a Medicare or Medicaid provider, within compliance of their policies. But it has to be a case-by-case basis where you look at it and say, yes, there is a genuine financial need. And another thing that I have seen practices do with these high deductible plans coming out, and with, if you're a relatively healthy person, you're never going to meet your deductible for a year, sometimes it's better to say, you know what, just treat me as a cash patient, and you can offer that prompt pay discount, because those are actually perfectly allowed, because you're allowed to consider what the cost of actually billing and collecting that money is from the insurance, and in a lot of cases you can include a discount there if they're willing to pay on the spot. So short answer, it depends. There are times where it's perfectly okay, and there are other times where it's going to get you into trouble. So I always recommend review your contracts, review the compliance guidelines for Medicare, and if you're not sure, ask somebody else for advice.
Very good. That was a very thorough answer.
So yeah, I know it's a little long-winded,
no,
but
I'm sure
that's the one where I don't want anybody to say, but she said I could.
Understood. Okay, the next question is it's a two-part question. How can I access the information you mentioned for my practice, and what systems should I be looking at?
I'm going to throw that one to you, Matt.
One, sure. Depending on which practice management system you all are using, it'll vary in terms of the analytics that sit on top of it. Most PM systems have standard reporting out there. They have data mining, query writers, etc. I definitely would make sure that there's a higher level of summary information. So actually taking the data that goes into your PM system to drop that claim and get paid, it needs to be rolled up into a higher level so that you can really see the key performance indicators, similar to what we showed earlier in the presentation. I think in terms of systems, I mean, the data is out there everywhere. You know, you're obviously going to pull a lot of data from your PM system. There's going to be times where you're going to want to pull data from your EHR. There's going to be times where you want to combine the EHR data and the financial data to really tell the story, especially when you get into regulatory, macro, MITs, PQRS, and things like that. So, you know, the nice part of the digital age of healthcare is it's becoming very digital, and the structured data can be pulled and accessed fairly easily, and as long as you have the right presentation layer, you're going to be good to go.
All right, great, thanks, Matt. Another question that came in is, can we call patients after office hours on outstanding balances or to confirm appointments?
So again, short answer is yes. However, anytime that you are going to be making calls related to patient balances, you want to make sure that you are following the guidelines for fair collection practices. And I'm a big fan of Google. Anybody can go to Google and just Google the term fair collections practices. It's spelled out very clearly. There are things like, you know, you can't call and be harassing, you can't, you know, but you are not limited to business hours. You are limited to, I believe it's no earlier than like 8 o'clock, I think, in the morning, and I think it caps off at around 8 o'clock at night. So there are some limits, but again, Google that information. But, you know, most patients, that's going to be the best time to catch them, because if they're at work, they're not going to be, you know, able to answer their phone. So yes, you can call after those hours, but I strongly recommend make sure you do your research on what fair collections practices are, what the guidelines and regulations are with that, and they're pretty straightforward. There's a document I actually just downloaded not that long ago, just to refresh and make sure that they haven't changed the rules on us.
That was a good answer, Amy. All I was going to say is, well, they certainly call me after hours.
That's true. Okay, just one more. I think this one is pretty quick, and then we'll wrap it up. Is there an easy way to reduce the number of rejections that I'm getting?
Why, yes, there is. And Matt, I can't believe we didn't talk about some of the claim scrubbing. We kind of missed that one. I'm going to let you go with that one.
Sure, absolutely. You know, it kind of goes back to, you know, the core features and functionality in your PM system, and making sure that, you know, there are claim scrubbers out there that, you know, you can build those bridge routines and really increase that claim pass rate. It's a rules engine, and, you know, where we were, again, 10, 15 years ago is a lot different than where we are today. And we've seen that with a lot of our clients already in deploying what we use in our PM system is getting, you know, whether it's additional information requested from the insurance company, you know, hold this claim for that. It's trying to make sure we're doing everything right before that claim goes out, so that when it does go out, it goes out clean, it gets paid appropriately, and we move on to the next one. So that's definitely, when I look at a lot of the analytics for our client base, coding and charge entry denials is always in the top 3. Additional information requested is up there. You know, so there's definitely opportunities out there to build rules, to put those modifiers on, to, like I said, create those bridge routines to be able to get those claims out clean. Good question.
Good answer. All right.
I think that we did actually have a few more questions, but we're really running out of time at this point. So if we missed your questions, we will follow up with you individually, or you can feel free to reach out to us. Here's some ways to contact us. You can go on our website and fill out a form, contact us page. You can email info@medevolve.com. Those emails actually come to me, Ashley Moore again, and I will make sure they get in the right hands. Or you can call our 800 number and select option 4, and that will take you to our sales team. And other than that, we really found that this topic was very popular. There's a lot of interest in similar topics, so we actually plan on turning this webinar into a series. So keep an eye out for future invitations. They should be coming soon. And I hope you all enjoyed the presentation and enjoy the rest of your day. Thanks, everyone.
Thank you all.
Thanks.